Hi, and welcome to
Thank
the show. Subscribe at kevinmd.com/podcast. Today, we welcome Scott Burnham. He's an emergency physician. Today's Kevin MD article is The Real Work Starts After a Mental Health Crisis. Scott, welcome to the show.
Kevin, thanks for having me here. I'd like to share a little bit about myself and my story. I spent 23 years as a board certified emergency physician. The training was to stay calm in the chaos and make tough decisions under pressure, hold the line, and I did that for most of my career. What I wasn't trained for and what nobody told me is that you could be doing all those things on the outside while quietly falling apart on the inside. And I developed or had depression, and it started the way it often does with clinicians, is gradually. I was able to rationalize all those signs and symptoms away, that it was due to long shifts, no sleep, I'm getting old. And by the time I couldn't rationalize those ideas away anymore, I found myself after a long shift in the parking lot of the hospital, unable to start the car, and just could not go home to face another day. And eventually, what I did was I asked for help. It was something that I had seen patients do my whole career, but I finally decided I needed to do that myself. I made an appointment with a family physician. It was actually one who I had trained in the hospital when she did her rotation through the emergency room. And what followed that was 2 years of medication, adjustments, therapy, and learning about myself, things that I'd spent my career trying to avoid. And by the end of that, I had what I realized was a roadmap helping you find your way from the crisis to recovery. And that's the book. It's Lifeline. It exists because the system that I worked in is very good at stabilizing people, but very poor at helping them figure out what comes next.
So, you were an emergency physician for 20 plus years, and then, like you said, these symptoms of depression started insidiously. What specific symptoms are we talking about? How exactly did you feel while you were working in the emergency department that made you feel that something more was going on?
Well, that's a great question. The signs and symptoms of depression, I knew clinically, I knew them intimately from being able to describe them to see people. But when they happened in myself, I was able to just ignore them all. As a physician, you're taught to push through, to work harder, and you have this professional competence that makes you think that you're doing okay. As long as I could work in the emergency room, I thought I was doing fine. But these symptoms were, loss of enjoyment, not able to sleep well, moods were shifting, and I just was not enjoying life. It was a dark cloud, and that took its toll on me.
And you mentioned that scenario where you were sitting in your car dreading the next day because nothing likely was going to change unless you made an intervention. So you went to your family physician. Tell us a little bit about that conversation and how that went.
Yeah, I came to the point where I knew that something had to be done. There was a fork in the road, and I needed to make a choice. There were dark thoughts, but nothing devastating or like I wanted to hurt myself, but just I needed this pain, this darkness to go away. And that was the time I decided I would call and make an appointment. I had never had a family physician before, never seen a doctor. And sitting in that waiting room was just exposing. It was an experience that I could not imagine I would ever have. I finally got back into the room, and when she came in and said, "What brings you in today?" All my thoughts that I had to explain vanished. And all I could say was, "I'm in a really bad spot and I need help."
And what happened next? You mentioned the role of medications. Tell us about the time course and that journey to recovery.
Yeah, what I found was that the journey is not a quick linear process. She put me on medications, gave me referrals to psychiatry, counseling, And I was to take these on. The When I walked out of the office, I wanted to get these appointments. I wanted to get started, but the time frame, the waiting, the delay, the gap between getting treatment and actually starting the recovery is prolonged and enormous. And there's this gap that we have a problem with in our system that does not allow the patients to have guidance on what to do after. You see, I wanted the Zithromax treatment. I wanted 5 days, I'll be better. I wanted to jump on this problem and get it corrected so that I could go back to work the next day. And that's the journey that I learned, is that it's not a quick process. There's ups and downs, there's cycles. I knew clinically what I needed to do. Exercise was important, yet it took me 2 years to be able to walk around my neighborhood on a regular basis. So there's this gap between knowing what to do that'll help and being able to do it. And that's one of the things I learned.
So you mentioned that you wanted that instant fix, but
Yes.
you talked about something like gaps. Like I'm going to infer that it took a while for you to see a behavioral health specialist after your family physician suggested that you see one. In the interim, while you were waiting, were you just on medications? Just tell us about some of the gaps that persist, because this is something that many of our patients, of course, deal with every day.
You're absolutely right. And what it took was for me to experience this on both sides of the table, both sides of the gurney. I was the physician for 23 years treating mental health patients. I thought I understood what they needed and how to give it to them. It wasn't until I was the patient on the other side where I saw what was missing. There is this gap that our system doesn't have a protocol for. In the ER, we see the patient, treat them, provide them discharge instructions. We advise them to follow up as soon as they can. And we give them a list of phone numbers. That's it. We call that our job well done. But there is this gap between stabilization and really being well. And that gap is enormous. And that's where the relapses happen. That's where patients' families get lost.
Mhm.
That's where the work that we did in the acute setting gets lost as well. So there's this gap and that's why I think it's important with your clinical audience that this is the perfect opportunity to express how important their acute treatment is, but there's more that can be done on the discharge end. We can remove the language of shame. We can provide more than just numbers. We can actually help them and guide them to get this help.
What do you mean by the language of shame?
When as a physician, I have all the answers when the patient walks in.
Mhm.
And I was the one that was supposed to fix people. I was the one that was not supposed to have problems. I was not supposed to ask for help. There was this professional shame that comes in asking for help. It's almost like saying, "Hey, I'm not cut out for this job." We know the data on physician suicides. We know the addiction rates. We know the untreated mental health in all of our healthcare workers. And that is tremendous. And that comes from training our our group of people to push through our own suffering silently.
So let me ask, Scott, how are you doing today? Are you back at work? And if you are, what has changed today compared to where you were in the past?
Well, thank you for asking. I have retired from the emergency room. I no longer do clinical shifts. I have transitioned to a few other roles, and one of them being mental health advocate. And that's where I find myself. I find looking back that this journey has been a tremendous learning experience, and I have to be grateful for it. I never will be the same person I was before, but I understand that. I still am on small dose of medications. I still regularly see my counselor and family doctor for follow-up.
Now, how much of the recovery, of course, was the support and behavioral health treatment that you were on versus just being away from the sometimes toxic environment that clinical medicine is today?
That's a great question. The work environment is toxic and it definitely has changed. That part did give me a space to be able to focus on myself. I feel that for the years of giving, treating, that was one of the things that I lacked was self-awareness and self-care. The therapy helped me see that that was important to do to get my mind back in the game. Medications helped stabilize. The counseling helped me understand about myself the things that, again, that I had hidden for years that we didn't want to address. So it takes both medications, both therapy and counseling together to be able to help the healing process.
So, what kind of advice do you have for other emergency physicians who may be where you were years ago, and maybe you don't, you don't want them to reach a crisis point before acting? So, do you have any advice for these physicians who are still practicing, sometimes in these toxic environments?
That's a very strong point that does need to be spoken about. There are things that I want every clinician in the audience to know about. First one is that you're not immune. Your clinical knowledge does not protect you. It does not make you a faster healer. In fact, as we've spoken about, if anything, it gives you the tools for denial. And I use mine for years. A second thing that I would like people to understand is that the patient experience is not what you imagine from the other side of the table. You know, I spent the 23 years caring for mental health crisis patients. And again, I thought I understood it. There's shame at discharge. There's paralysis when they go to the pharmacy counter. There's the inability to do things clinically that that I knew what we needed to do that are just impossible to do. There's the gap between knowing and being able to act. And we don't account for that when we discharge our patients. And when we don't, we are handing them into the instructions to go into the world that they're not ready for. The third thing that I think is important is that asking for help is a clinical act. It's not a personal failing. I tell clinicians that I run across and talk to that I mean it, or I tell clinicians that we need to give ourselves the same grace that we give our patients. When they walk into the emergency room at their worst moment, we ask them to be honest about what's happening. And we have to be willing to do that ourselves. And the physician who is going to get help isn't the weak one, but he's the one that's going to be around in 5, 10 years.
As you know, in medicine, there's a culture of shame when physicians need that help. It prevents physicians from asking for that help. It prevents physicians from being vulnerable. Now, I want to thank you, of course, for sharing such a vulnerable story. As you were going through this, what were some of the reactions that you could perceive from your colleagues, your family? Did you hear any whispers as you were going through this vulnerable period in your life?
The the support from loved ones was tremendous, but you had to let them know. I had a hard time asking for help. The the pride, the physician culture did not allow me to speak about it until I got to the very bottom. When I was finally able to admit that and speak about it, the support was tremendous. I think it was very surprising the amount of coworkers and colleagues that would send a note, a text, and say, "Hey, I've been there. Hey, we're thinking about you." There's a lot of silent suffering in healthcare, and that's basically the physician culture on display. We all have the vocabulary to speak and describe what we're going through, but yet the professional risk is too great to want to do that. And I think going through this opened my eyes that sharing my story was kind of like a permission slip for coworkers and colleagues to say, hey, if this guy who's been in the ER for 23 years ends up in a parking lot, unable to start his car, maybe I should be honest about where I'm at today. And asking for help is one of the bravest things that you can ever do.
We're talking to Scott Burnham. He's an emergency physician. Today's Kevin MD article is The Real Work Starts After a Mental Health Crisis. Scott, let's end with some of your take-home messages they want to leave with the Kevin MD audience.
What I'd like people to know is that the mental health crisis that one experiences is not the end of the story. It's actually the turning point because the energy, the effort, the treatment that goes into the next weeks and months after somebody leaves the ER or the hospital is actually where the recovery happens or it doesn't happen. And we built a good system at stabilizing the crisis, but we're almost indifferent to anything that follows after. And the book Lifeline exists to fill that gap. This book is for patients, family, and people that love them. But for our clinical audience that you have here, my message is really that the work that you do in that acute setting matters tremendously. And it's not enough to just hand them a discharge and a list of numbers. We need to provide them guidance, care, support. And if there's somebody in the audience right now that is struggling, or you know somebody, a friend, family, that's who this book is for. And if there's somebody that this resonates with right now, 988 is a number that's available 24 hours a day. And again, the bravest thing you can do is ask for help.
Scott, thank you so much for sharing your story, time, and insight. And thanks again for coming on the show.
Thank you, Kevin. Appreciate your time.